There was a great study I read in an ophthalmic journal, eyes, on laser eye surgery, LASIK, and they talk about the complications of laser eye surgery. And that's where you lie on your back and, you look at a little dot and they laser scour the surface of your eyeball. Now, the reason why I was reading is because I wanted laser eye surgery as well. And I wanted to look at complications and complication rates and how I as a consumer, would avoid going blind because I'm a surgeon. And the problem is, as a surgeon, going to another surgeon to have something which has the risk of blindness, or it's not blindness in the sense you can't see, but blurriness.
Sure.
What is that risk? And the surgeons, of course, they're all as nervous as pie, um, talking to you or even with the prospect of treating you, because if they cause this blurriness in you and you can't operate because of that, their reputation becomes throughout the community that
Sure.
he causes problem in the other surgeon.
Sure.
And that just spreads amongst all the doctors and all the referrers and all the hospitals and so forth. So when I go to the surgeon, I've got to be careful myself that I'm not exposing him to that risk or her. So I'm sitting there and I've done my research. And this is the research. The complication rates of laser eye surgery run at around about 4% or 3% of all laser eye surgery. But the complications, when they occur, only occur in one part of the bell curve. And what I mean by that is, if you look at all procedures of laser eye surgery that are performed, you can then measure out of that entire number the percentage of complications, known complications, a specific complication. And for this specific complication, you would say it's 3%. I'm just making it up, but let's say it's
Sure.
3%. Well, for laser eye surgery, it turns out that all of those complications don't occur evenly distributed through the bell curve. If you look down at the numbers, they occur only within the first 100 or 1,000 cases of a laser eye surgeon's practice. And it
Right.
occurs right at the beginning.
Mm-hmm.
So it
Mm-hmm.
occurs with two events. The first is that the ophthalmic surgeon's just graduated from ophthalmic training and he's just entering private practice. And so he really hasn't got a big experience. He's only done a few of these things in the public hospital system, but now he's entering the private system where they do literally thousands and that's their entire forward career.
Mm-hmm.
And the other variable was how old the machine was. So if it was a brand new machine and you didn't know how it worked, then the complication rate was almost 90% for the first 100 or 2 or 300 patients.
Wow.
Well, incredible. But after that, the complication rate became zero.
Mm-hmm.
So then the performance or the predictive outcome was then to say, well, who's the older surgeon? Who's the one that has done the most repeatedly and with frequency, meaning he hasn't done 1,000 up to about 3 years ago and then hasn't done any since? And who's the one that's been using the older machine, not the newer machine?
Sure.
Meaning he's used to the equipment, he's used to
Yeah.
the facility, he's practiced, he keeps practicing, there's frequency to it. And at that point, he becomes zero risk. So how do you
So,
pick a surgeon for
yeah.
corrective jaw surgery? Well, you pick the guy that does it 98% of the time and maybe 2% of the time, has to do something else. You don't
Sure.
pick the guy that does 98% of taking out impacted wisdom teeth and dabbles rarely in something that, the orthodontist doesn't want and he's not that well practiced or versed in anyway,
Right.
um, if that makes sense.
So that would be criterion number one, would be find the surgeon who primarily does orthodontic surgeries rather than tooth extractions. But then even once you've gotten past that level, so
Mm,
say, for example, on my channel, I think let's say 10 or so oral and maxillofacial surgeons that I discuss on my channel that keep coming up from guests I speak to or referrals made by top orthodontists that I speak to.
Yeah.
What's the next layer of discernment besides finding the person who does only orthognathic surgeries? For
Well,
example, how do you? This is the one that gets me.
mm,
How do you find the person who you know is going to bring attention, quality, uh, discernment the day of? How do you avoid the hack, right? Because
right. Yeah.
anyone uh, anyone is only as good as they are in that moment. I mean, if you have Leonardo da Vinci, but
Mm,
he's hungover and
right.
he's in a hurry because he's off to do something else, or maybe he's been commissioned to do 10 paintings in a week instead of
Right. Yeah.
instead of one painting in a week where he can focus and get it right.
Yeah.
How do you figure out who that person is? Who's the
Well,
hack?
I've got a great way to explain that. Um, First off, it is impossible. It is impossible to to treat more than four new patients a week in orthognathic surgery,
Why is that?
because the time commitment that's given just to one single patient is overwhelming.
Yeah.
Yeah,
Tell us about that a little bit more. Like,
overwhelming,
so
overwhelming.
now we're getting a little bit more microscopic, and maybe in zooming in on this, we can identify some questions that could be asked of a surgeon. So, like, what's part of the patient workup
Well,
process, or ought to be?
if you're walking into a room, a waiting room of a doctor, and he's got 20 people there waiting for him, yeah, to see him, he can only dedicate 5 minutes to each and every person.
Mm,
But if you walk into a maxillofacial surgeon and he's got 10 people waiting in the room, and you're there to have this incredibly complex process go on called orthognathic surgery, you're competing against those 10 other people for his attention, time, thoughts,
mm,
mind.
mhm,
Yeah.
mhm.
You want to walk into an empty room.
Sure.
You want to walk into a room that's calm, devoid of all conversation, and it's all about you.
Mhm.
And you want to be able to sit there and talk. You want to be able to explain your condition, be heard, be felt that you're heard. And of course, it flows on from there in that environment of it's all about you.
So, doctor, could we say in general that teaching universities and where an oral maxillofacial surgeon is employed
Mm.
would probably be a plan B at best, because the doctor is not really able to
It's not a plan B. That's a plan Z. That's a
really.
last desperate hope.
Hmm.
That's standing at the border at Ramallah, hoping that the Egyptians let you in, getting
Right.
out of Gaza.
Right.
Right?
Yeah,
That's
not a place you want to be.
you don't want to be there.
No.
Right? Do you know what an inducement to treat is?
No. Tell us.
Well, an inducement to treat. If you came to me for jaw surgery and I said to you, "Hey, can I treat you? And I'm going to give you a bicycle. Would you let me operate on you?"
It would be a huge red flag.
It
I
would be,
want a
wouldn't it?
surgeon who I'm chasing.
Right, but that's called an inducement to treat. Yes. Now, let's say you come and see me and you don't know me from a bar of soap. You've never met me. I'm 25 or 30 years old. I've got a white coat on. And I say, "Hey, you don't know me. Can I treat you? I've never done this before, ever. I've read it out of a book, but I'll do it for free. Would you let me do it?"
Negative.
Well, that's called an inducement to treat, right? I'm offering you either a bicycle or I'm offering to do it for free. Yeah.
Yeah.
Well, that's called a public hospital.
Hmm.
That's your
What's the
plan Z,
inducement? What's the inducement at a public hospital? What?
or you're getting it for free.
Right.
And the reward is that the fellow who doesn't know what he's doing is getting to give it a go.
Mm. Mhm. Mhm.
I mean,
Yeah. In
how
in the
correct is that? Yeah,
hospital
philosophically.
in a at a big teaching hospital,
Or
the
who's
surgeon
teaching?
never chooses his own schedule. That's imposed
Well,
on the surgeon by the administration,
but they're not
and they're
surgeons.
they're profit driven
But they're not
exclusively.
surgeons. They're not
What
surgeons.
what are they?
Or you call them a surgeon.
Mm,
They're trainees. You
mm,
only get to be called a surgeon when you graduate.
yeah.
So
So
they're not graduated, and they're being taught at a distance by somebody who's in their private practice,
right, right.
right? So what you're getting is the 20, late 20s, early 30s fellow or woman who doesn't know what they're doing.
You're getting the resident.
Yeah,
The resident is actually going to be um,
right.
cutting into you or
Yeah,
stitching you back up, and
yeah, with
maybe
distant,
the
yeah, with a distant instruction as to possibly how to do it,
yeah,
right?
yeah, yeah, yeah.
And
Maybe they'll call in
the
maybe they'll
inducement is to do it for free.
mm,
So,
yeah.
that is your option Z. I mean, it's there. And the vast majority of people who cannot afford treatment, that's their option because they say, well, I can't afford it. I will accept that inducement.
Hmm.
Yeah. But me who can afford whatever, I'm not going to accept that inducement. I simply use the normal exchange of what we call money. And I say, I will pay you because you're the very best at doing what I want you to perform. And I don't want these known complications to arise in me. And I will come to you because you, independent of the public system, have developed a hospital service in the private system, which has 20 other hospital staff, nurses, nursing assistants, surgical assistants, recovery assistants, anaesthetists, like retrieval specialists, the best, who are also paid to be the best and are all qualified, all fully registered, all fully trained already. And repeatedly, that team of people, repeatedly, over and over, do that only that procedure. Now, that's your option A.
Mm,
So, I, as a surgeon, I mean, you can see I'm just sitting here in a studio. I'm not a surgeon in this studio. I'm a surgeon in a hospital. I'm a surgeon when I'm surrounded by people and technology and instruments and safety. But you wouldn't have me operate upon you at a camping ground devoid of anything but a steak knife. You want
right.
the facility. You want everything and all the accoutrements that come with being a surgeon, which is the hospital.
Sure.
So if you're walking into a dingy little surgery centre that won't let you stay in overnight and is only going to give you IV sedation and with a limited range of instruments and a surgical assistant who's never seen the operation or even knows how to hold a retractor, with a surgeon who is not used to performing the procedure and is instead just doing routine lumps and bumps, or just graduated, or is even falsely using the title of surgeon, and lots of people do, you walk out the door.
Hmm.
Now, the reason why I know about that is because, you see the consequences of that, and they're called, can you please, 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 now I have the insight as to what I'm looking for. Can you please, please, please redo my Bimax, which is a ridiculously complicated operation, the, the repeat Bimax, because you're not just treating with a Bimax, you're reversing what the other amateur did beforehand at his reduced rate and inducement to treat for free or, subsidy or discount or whatever, just simply to induce you into a treatment that you otherwise would not have had
Sure.
if you weren't given the inducement.
Right.
Yeah. So inducement
So
to treat is such a ridiculously unethical practice to practice. And, any system that promotes it is just so fundamentally wrong. The premise of it is wrong.